Hello, everyone. My name is Chahao Hua. I'm a medical physicist at St. Jude's Children's Research Hospital in Memphis, Tennessee. And this is the first presentation of the section, and I would like to provide you an overview of pediatric radiotherapy, photon, proton, and beyond. One-third of children with cancer receive radiation therapy as a part of disease management. For adult patients, it was about 50%. The good news is 84% of children with cancer now survive 5 years or longer. This table shows the major diagnoses of pediatric cancer, and CNS tumors are the most common to be treated with radiation therapy. Although leukemia is also a very common pediatric cancer, radiation is usually not part of the main treatment for acute lymphocytic leukemia. And other pediatric cancer you will see in the radiation oncology department include retinoblastoma in the eye, Hodgkin and non-Hodgkin lymphoma in thorax, neuroblastoma and Wilm tumor in abdomen, rhabdomyosarcoma and bone cancer in anywhere of the body. An average 5-year survival is excellent, but some pediatric cancer have very poor outcomes, such as diffuse intrinsic pontine glioma, so-called DIPG. Only 2% would survive past 5 years after diagnosis. Because many children survive pediatric cancers, the late effects from pediatric cancer therapy become very relevant. And many large studies follow childhood cancer survivors who were treated in 1950s to 2000 and report significant late effects after radiation therapy. And these late effects may include neurocognitive and learning problems, hearing loss, vision, dental problem, endocrine dysfunction, cardiovascular disease, pulmonary dysfunction, height reduction and skeletal deformity, infertility, as well as secondary malignancy. The pediatric cancer community has been testing the feasibility of reducing the total dose, eliminating RT for early stage patients, and apply highly conformal RT techniques. So effort in reducing toxicity seem to be working. A recent report showed the risk of heart disease is falling among survivors of childhood cancer. But normal tissue toxicity still exists, and more work needs to be done. For treatment delivery modalities, photon beam generated by a linear accelerator has been around since 1950 to treat pediatric cancers. And proton beam is also not new. However, it wasn't until the past decade that we have started to see a steady increase in the use of proton beam for pediatric cancers. And there are a few less common treatment modalities. And carbon ion therapy has been used in Japan and Germany to treat base of skull tumors and osteosarcomas. And brachytherapy in the form of iPlaque and HDR is being used to treat retinoblastoma and soft tissue sarcomas. The MR-guided RT for pediatric cancer has been used recently to treat sarcoma in the diaphragm because pediatric brain tumors are often large, so SRS is not very common. On the other hand, SBRT has been used to treat bone tumor under clinical trial. So according to a recent survey of practice pattern conducted by Children's Oncology Group, the choice of RT modality reported by pediatric radiation oncologists really depends on the disease type. And proton therapy is a red color in this bar chart. So overall, the photon therapy is most common RT modality in treating pediatric cancer. The survey also showed only 20% of pediatric radiation oncologists have direct access to proton beams. And there are 2,100 radiation oncology sites in US, but only 31 operating proton centers. It was estimated 1 in 5 pediatric radiation treatment in US is delivered with proton beams. Although the capacity is currently an issue, and new proton centers are being built every year. The trend in pediatric radiation oncology is to move from high dose, large field to lower dose and conformal treatment. As shown on the left panel, Hodgkin lymphoma is a good example. For selected diseases, we still treat whole brain, whole lung, whole abdomen, and TBI in an old-fashioned way. But IMRT VMAT and protons are being proposed to provide better OAR sparing. For example, a CSI can be delivered with intensity modulated proton therapy, sparing organs anterior to the spine without the need for a weekly junction change. So the question remains, if we don't treat most children with proton beams, are we not offering the best treatment? So how do you know the photon or proton plan is as good as it can be? And how would you advise if your best friend asks you about proton versus photon for his child recently diagnosed with cancer? And should we proceed slowly with caution, or is it time to embrace the photon technology? So what can we do as medical physicists? Many non-technical factors affect the decision on the treatment modality. For example, the clinical evidence, reimbursement, and patient ability to pay, and access to proton facility, and the ability of caregiver and child to travel to another city for treatment, and physician's referral preferences. However, we as medical physicists should control what we can control to keep up with technology advances and optimize its clinical application and understand the achievable and limitation of each RT modality. And through this point-counterpoint section, and we hope to stimulate the discussion and raise awareness of childhood cancer in the medical physics community. Well, thank you for listening. And next, we have two speakers to argue for and two against the proposition, which is most pediatric cancer patients should be treated in proton therapy centers.